2 and stage 3. So what is stage 3? Placenta delivery. How do we know placenta delivery? Page 16. On placenta delivery, the cord is getting longer, bleeding is profuse. How long do you take the time for placenta to be delivered? Within 30 minutes. If placenta is not separated, that means there's a problem in contraction. Encourage mother to have urination, empty the bladder. Then next is stage 4. Stage 4 is we are monitoring the mother for 4 hours. First 4 hours is called stage 4. First 4 hours, what do you monitor mother? Mother would have, number 1, shivering. She lost a lot of blood. Fundus, where does the fundus remain? That's important. Midline and 1 to 2 finger below the umbilicus. Shouldn't be very high. Should be above or at the level of umbilicus area. Shivering is there. Monitor the mother and monitor for lochia. Lochia is the bleeding. Moderate to heavy is first 2 hours. And lochia, bright red, may have some clots in there, and slowly it decreasing. Monitor how frequently you should monitor stage 4. Every 15 minutes for 1 hour, then every 30 minutes for another hour, and then every hour for 2 hours. So that's important, 15 minutes, 30 minutes, then hourly until 4 hours you stabilize the mother. Now remember, we are nurses. Your questions is priority. If you are in labor and delivery or any place, which patient would be priority? If you are the mother had delivery and you're going to transfer her to the floor or wherever she's going, is which would be your priority to assist or to assess in labor and delivery or recovery room? The mother who's going to be transferring. Remember, admission, always your priority. Whether you are in a labor and delivery, whether you are on the floor, and they give you a question, your priority questions are, number 1 is admission. Somebody is admitted today. That's your priority to assess. Patient who's going to be transferred from labor and delivery to the floor. Which patient is going to be transferred? Before you transfer, aren't you going to visit her first? Yes. And so transfer. Same thing in your med-surg unit. Anywhere, nursing home question. Patient comes in, go and assess, look at the patient's condition. Patient who's going to be transferred, mother is in labor and delivery, finished 4 hours, she's stabilized, and she's ready to be transferred. And they are giving you are working in labor and delivery, which patient are you going to visit first? Patient who's going to be discharged. You don't want to discharge those who are not stabilized. Same thing, you are in med-surg, you're going to discharge your patient, you've got to assess. Anything happening today, remember in your mind. Patient fell today is your priority. Are we clear? Patient maybe blood sugar is 400, but you are not going to go 400. Which one are you going to go first? Patient, because patient fell. You got to assess. Patient is going for new G2 surgery. Patient is going for dialysis. I'm just giving you example. Remember, your questions are going to be a lot of critical thinking. So if you are in labor and delivery and you are discharging the mother, she's stabilized, your job is first, you're going in the morning and you will visit your patient first who are the one are going to be discharged. Are they okay? Their paperwork is ready? Are they stabilized? Their vital signs are okay before you discharge them. So keep that in mind. Anytime admission, discharge, you're assessing first. Next is in the same paragraph, the blanket is good, massage the fundus, breastfeeding, support also for contraction of the uterus. Next page, is some of the procedure and the wording I have here, and I want to go over a few wording. Bishop score. What is the bishop scores are? And bishop score is determination of, underline the word, maternal readiness. That means the mother is ready for labor. If they give you the word, what is a bishop score is, you are assessing the mother for readiness for what? For labor, induction. Induction or to have a labor. What are you checking? Number one, dilation. Is the mother is dilated? Cervix, effacement, and also position and the station. Where is the what station the mother is in? Oxytocin, IV when you give. Second line, induction. Induction means mother is not having a labor and we are starting the labor. But how do you start her in labor? By giving induction. Induction means you are inducing is the contraction and you are inducing with the pitocin. So underline the word induction elective. Your mother was not progressing. Mother is not having delivery. So what do we do? Induction word. Monitor the fetal heart rate every 2 to 3 minutes. And hyperstimulation occurs. You are starting pitocin. Contraction comes too fast word or hyperstimulation and fetal heart rates are not good. Stop the oxytocin. So when they use the word induction, induction means mother was not progressing and we are starting pitocin, check the fetal heart rate, vital sign and stop if the contractions are too fast. And the word is called AROM, artificial rupture of membrane. Normally it ruptures. Mother who's not going in labor, they have to rupture the membrane. And before you must rupture the membrane, mother must have what? Engagement. The baby is down and before you performed. Monitor heart rate. And any unpleasant odor coming could be sign of infection. When you are inducing labor, any bad odor, sign of infection. Polyhydramnios word, too much of amniotic fluid. And what does it, which patient you will see polyhydramnios? Diabetic patient. And what does it can lead to? Congenital. If they have too much of fluid, amniotic fluid, monitor for congenital defect. Oligohydramnios, less fluid. And less fluid can cause also growth restriction and congenital disorder. Both are not good. Polyhydramnios and oligohydramnios means too much of amniotic fluid. Now, if mother has amniotic fluid or bag of water rupture, what do you tell the mother? Come to the hospital right away. What do you monitor when the membranes have been ruptured and is infection? Everyone keep that word in mind. Next is the word episiotomy. Episiotomy there are midline episiotomy, and I will ask you maybe to add that. Episiotomy, they give the cut. And midline, there are two kinds of episiotomy. Midline is more in the middle, like this, and mediolateral would be on the side. So there are two kinds of episiotomy, is middle, and it's called midline episiotomy. So number one, midline, it's usually elective. Elective means they select this side to do it. And they can repair easily and less painful, less pain here. Mediolateral, this is on the mediolateral. So one is midline. Midline is usually they like to do it because less pain. Then you have mediolateral. Mediolateral, when they have, the blood is greater, they lose a lot of blood. Blood loss is greater, that means they lose a lot of blood. And difficult to repair. difficult to repair. Difficult to repair. When in your question, patient has mediolateral episiotomy. When you are cleaning or pericare, what position you will put? Left side. Turn the mother on the left side, or left Sims position during pericare, and left lateral. You can go left side, left lateral, or Sims position on cleaning. Now, so there are two kinds of episiotomy. Midline, elective, usually they like to do midline. Mediolateral is they lose more blood and also difficult to repair. And when you are cleaning is a little harder, so you got to turn the patient on the left side. Now, in episiotomy, incision is made. And why? To open the perineum bigger. And postpartum is monitor. What do you monitor after? What is the purpose of episiotomy? To prevent, what are we preventing here? Laceration or tear. You don't want to have a bad tear. And you give more room for the baby to come out. After the baby is born, monitor episiotomy for pain. What do you apply first 24 hours? Ice pack. Ice pack is your answer. After 24 hours, you will go on sitz bath. Cleaning, we all know front to back is good. Area, don't rub hard, blot, the word is good. Blotting or padding word is good. Shower is good rather than tub until the area is healed. Forceps delivery, you monitor also for laceration, and vacuum delivery and suction is applied and can lead to a lot of injury. Now, I want you, there are two words here with the baby's head injury are cephalhematoma word and caput succedaneum. There are two wording here. And we have more in the next page, so I won't go over because you don't need to write it. But when you have difficult labor, or you're using forceps or vacuum, it can cause injury to the baby's head, and those are cephalhematoma. C-section question. Mother is going for cesarean. What do you prepare in your question? Number one, Foley catheter. As a nurse, we must look for the answer. Mother is scheduled for C-section. How do you prepare the mother? Consent is there, cleaning, whatever you needed, but Foley catheter. We got to put the Foley catheter. Post-op care. What do you teach the mother who come back after C-section? Cough and deep breathing exercise. Lochia. If it is foul smelling. Mother had a C-section, but is still infection. Underline the word, sign of endometritis. So endometritis is the layer of the uterus, endometrium. There's infection. And what is the foul odor is coming? There's infection, sign of endometritis. Mother had a C-section, could have endometritis. And the third line, very important, very common complications are thrombophlebitis. Everyone remember three wording here. Number one, before mother is going, your question, what do you do? Prepare the mother for C-section. What do you do? Foley catheter. Consent is important as mother is going. And when she comes back, breathing exercise. And what are you preventing? Thrombophlebitis. You still monitor for infection. Any foul odor is there, sign of endometritis. We got to notify. So few answers are good. Now low temperature. If mother has low temperature, is okay, or is mother, but if they're running high temperature and they're running for consecutive 2 or 3 days, that may be sign of infection. So remember, monitor for infection, fever. Normal slight temperature is okay because could be dehydration. But if mother is running for 3-4 days, same temperature, that means you should monitor for infection. First 24 hours is okay. After that, infection. Next word is you have dystocia word. What is dystocia? Difficult labor. Mother is not progressing labor. What do we do? when mother has dystocia is hypotonic word to and pelvis of the mother. Second thing, contraction of the mother. Third thing, any infection, and also can lead injury to the baby. Mother is not progressing. Are we going to check the contraction? Is she getting any contraction? Are we going to check if she ruptured the membrane? And is she approaching to the labor days? Time is there, but she's not having any progress. Could be her pelvic size is not normal. Could be the position is not normal. And could be just delaying labor, but you've got to do all the assessment in your question. But as we understand the word dystocia, mother is not progressing in labor and she's having a difficulty in laboring the baby. So these are all your answers. Some answers are there. Monitor for contraction, hypotonic contraction, size of the pelvic area, monitor the fetal heart rate, and they may start Pitocin and prepare the mother for C-section. Data collection, dystocia can lead to fetal distress, check for the fetal heart rate, ultrasound, pelvic exam, we already talked about, and maybe Pitocin, and check the color of amniotic fluid. Prolapse cord, we talked about it. Prolapse cord, underline the word, can lead to variable deceleration. Bradycardia, baby's heartbeat are going down. What do you do for mother? Positioning, Trendelenburg, knee position, knee chest, Sims position, oxygen, fetal heart rate, and prepare the mother, check the fetal heart rate. Elevate the presenting part from the cord, which I said earlier, by using the finger with the sterile glove. And what deceleration you're monitoring? Variable deceleration. Next page is a little bit about the preterm question. Preterm labor means early labor. Pre means before. Early labor, mother is going maybe 20 or 37 weeks. Causes may be infection, unknown. Data collection would be in preterm. Is it painless, painful, cramping? Monitor for that. And bloody or odor, any drainage are there. And dehydration, bed rest, you put the mother. And if the contractions are too fast, maybe tocolytic medication to suppress the labor. Premature rupture of membrane. Premature rupture of membrane before term and delivery, monitor for infection. High risk infection could be. Nitrazine test, we already talked about it. What do you monitor when the membranes are ruptured? Fetal heart rate. And second line, temperature. Every shift, maybe some places every 2 hours they check the temperature. In an intervention, maybe antibiotic mother would need, fetal heart rate you monitor. Accident, mother had any accidental and can lead to her in early labor. Data collection, if she's bleeding, abdomen would be rigid, mother is going into shock, and intervention, treat the shock, IV fluid, and prepare the mother for C-section. Sometimes they may also have the hysterectomy. So question can be an emergency situation, dystocia word, mother is having infection, or mother ruptured the membrane. Any question, assessment, and what you're going to do, your priority. I will move on a little bit now, placenta previa and abruptio placenta. What is in placenta previa question? As I said earlier, placenta previa is already abnormal placenta. So this is the uterus, and this is a normal placenta. The placenta should be where? In upper uterine segment. So where is the placenta normally? In the upper uterine segment. So when mother has abruptio placenta, this is abruptio placenta. So remember, in abruptio placenta, when I'm talking, is what? Is the placenta is normal? Your first answer, always no. What is abruptio placenta? Placenta is normal. Where is the placenta? In the upper uterine segment. So let's go, let me finish abruptio placenta in your page. So underline the word premature separation. But on the top, write down normal placenta. You must know it's a normal placenta, and where is the placenta should be normally in upper uterine segment. So add that. And 20 weeks before the birth of the baby is premature. But what happened here is premature separation of placenta. So premature. So when the doctor, they did ultrasound, they saw the mother has a normal placenta. They're not preparing mother that she may lose the baby or she may start bleeding because they know the placenta is normal. But mothers start preeclampsia. Then the doctor would tell the mother, we got to be careful, your blood pressure is running high, maybe her health condition is bad. So what is abruptio placenta? Everyone remember, it's a normal placenta in upper uterine segment. But what happened? Early separation of placenta, and could be any reason for the mother to go through that. And what does the mother has here in data collection is dark red vaginal bleeding. The mother is having, so early separation, everyone must know premature separation, early separation of placenta, which was normal. And what is the mother is having here now? Bleeding. And mother start bleeding, and that's good. We all know is the bleeding. But what happened to the abdomen? It says pain and tenderness and uterine rigidity. I want you to add the word abdomen, because some question they will say, what would you assess in the abdomen? So where is the uterus? Uterus is right up here, and when you are feeling the mother, you can feel the abdomen is hard. And why? Because mother is bleeding, all the blood is not going down, and it's staying some blood in the back of the placenta because it's separating. So once it's separate, the blood is in the back. That is the reason is the mother has abdominal rigidity. And it says some of your question, abdomen is like a board, like a hard board. And mother is going in shock and fetal distress. So mother is bleeding, very important. And third thing I want everyone remember, abdomen is going to be hard. Because why? Because there is a blood. Now what is the reason mother is going abruptio placenta? In your exam, hypertension, preeclampsia, mother's health, maybe she has other health problem. Maybe mother is taking drugs, alcohol, that can maybe leading to her. So it's not because of the location of placenta. Are we clear? So what are the three things we remember? Abdomen is hard, normal placenta, upper uterine segment, early separation because of mother's health. Are we clear? That is why mother is losing that, start bleeding and losing the baby. And what do you do in abruptio placenta? Mother is bleeding. What kind of deceleration we have here? Abruptio placenta. What is the deceleration is here? Is, what was that? Late deceleration. Remember, mother is bleeding, placental insufficiency, mother is going in late deceleration. Baby is fetal distress is there. And what do? You monitor fetal heart rate, vital sign, oxygen, fluid. Turn the mother on the lateral or the left side. And why? It relieves the pressure on vena cava and improve the circulation. And prepare the mother. Now remember, the baby is right here. So the baby is laying here and the placenta is here. Now abruptio placenta, not necessarily the mother has to have a C-section. Mother just start bleeding and doctor knows the baby's fetal heart rate is normal, baby is still good, they can go vaginally and remove the baby. Only they will do C-section if the fetal heart rate is bad, and baby, or the word is fetal distress. Who we are preventing here? The baby. Baby is doing okay. They can do normal delivery. Right away they can take out the baby. Are we clear? Or C-section. So your choices are, in your question also read it all the time. There may be answer, if fetal heart rate is okay, how do you deliver the baby? Normally. If fetal heart rate is bad, then you're going on C-section. Why? Because the placenta is here. You're not touching placenta, you're removing the baby. Once you remove safely the baby, placenta would be out and the bleeding would be stopping. But let's go is placenta previa. Where is the placenta? This is the lower part, and maybe is placenta is here, or maybe more on here. And what is it here? When it starts growing here, placenta, the mother start bleeding. This is not normal. Are we clear? Where is the placenta? Now I want you to write down on placenta previa. You already have improperly implanted. It's not normally. Right from the day mother got pregnant, the placenta was normal. So when they have done their ultrasound, they already will tell you, is the mother, they are having a placenta previa, risk for bleeding, no lifting, do more bed rest because there is risk for bleeding. Are we clear? So what is a placenta previa here? The placenta is in the lower part of the uterine segment, or maybe covering. This is the word is os means opening, and maybe internal os. It may be covering the opening of the cervix. And so it may be very close, very lower part of the cervix. And as the baby grows and the cervix is dilating, mother starts bleeding because this is not normal situation for placenta. So everyone is okay, placenta previa, abnormal placenta. What is the mother is having bleeding here? Painless. Other one was they were having? Pain in the abdominal area. This one has no pain. And the blood is going out. That's why the mother is not going in DIC. DIC is only the mother is going in abruptio placenta. And now this one, no vaginal exam, nothing. Because why? As soon as you will touch here, you're going to remove the placenta. So this one, 100% has to be a C-section. There's no normal delivery, C-section. Both would be risk for saving the baby, they will go. But if fetal heart rate is okay, they can do the normal delivery. Now painless, bright red, and vaginal bleeding, non-soft, tender uterus means abdomen is soft. So write down there, the word abdomen is soft. So which one abdomen is hard? Abruptio placenta. Which one the mother is going in DIC? In abruptio placenta. Now, what would you do? Prepare the mother for C-section, ultrasound they will do, no vaginal exam. Legality question. You are admitting a mother who has placenta previa, mother is bleeding, and they give you a question, you prepare or you do vaginal exam, and mother lose the baby. Who will be legally responsible? A nurse and a doctor. Are we clear? So legality question like that, they connect you. No exam here, only ultrasound. So those covered with placenta previa. In the next one, I want you to cross out the word. It says disseminated, but that's not disseminated. It's a wrong printed. I want you to write down the word. We already talked about DIC. I want you to write down amniotic fluid embolism. The mother, there is a air embolism and there is amniotic fluid embolism. Amniotic is bad. Amniotic, if mother, amniotic fluid goes somehow in the circulation, it will cause really a bad embolism. So amniotic fluid embolism. There is a fat embolism, there is air embolism, there amniotic fluid embolism in OB. Underline the word. In amniotic fluid, you have vernix, hair of the baby, and it goes into the meconium and in the maternal circulation, and is caused, underline the word, pulmonary blood vessel and pulmonary artery. So it can lead to bad, severe problem with the pulmonary embolism. So amniotic fluid goes in the mother's circulation, can block the pulmonary artery. And it can also lead, what is another reason for DIC? If mother is in amniotic fluid embolism, you also monitor mother for DIC. That means is disseminated vascular problem. Data collection, severe cyanosis, and it can lead to respiratory and heart failure, and underline the word pulmonary edema. Pulmonary edema is bad, and it leads to severe breathing problem. What do you prepare the mother? Right away is cardiopulmonary resuscitation. Mother is not getting, or mechanical ventilation. Monitor the fetal distress. So mother has disseminated intravascular problem. What do you monitor? Severe breathing problem. Your another answer, pulmonary edema. They cannot breathe, pulmonary edema. Another answer, monitor for DIC. What do you do as a nurse? Prepare the mother for resuscitation and monitor for fetal distress. Next is sign of fetal distress are underneath less than 120, more than 160, the fetal heart is leading with the fetal distress. Next is fluid meconium stain. The mother has amniotic fluid. Anywhere meconium is there, monitor for fetal distress. Position, baby is going in fetal distress. What do? Is turn the mother lateral position, elevate the leg, discontinue the Pitocin, and give her oxygen therapy. Now, postpartum period. I will move on. Some question on postpartum period. Involution word. What is involution? After delivery, 6 weeks is your postpartum care. So when they give you a question, what is postpartum period? Is postpartum period is for how long? Is 6 weeks. So what is your postpartum period? Is 6 weeks. More than 6 weeks, if mother is not doing good and you're still keeping eye on mother for some reason, it will call late postpartum. What is normal postpartum? 6 weeks. More than 6 weeks, your word is late postpartum problem with the mother. So we are monitoring the mother. And what do we monitor? What happened in the postpartum word is called involution. Involution word is important. Postpartum word is important. Late postpartum after 6 weeks. What is the involution word? Within 6 weeks, decreasing in size of the uterus and returning to the non-pregnant state. So what happened? Within 6 weeks, uterus was still out. You can feel it has to go back in the normal condition. So what is it happening? The wording for your question, involution period is returning of uterus in non-pregnant state within 6 weeks. Everyone is okay? That word is called involution. And size is decreasing. Breastfeeding, mother may experiencing more rapidly because it helps in contraction. Breastfeeding mother normally will take in the regular time and would be good. Data collection is there 2 pounds to 2 ounces in 6 weeks. The size of the uterus was, or the weight, 2 pounds, and within 6 weeks, it's returning to 2 ounces. So that's important. Some question, they say, what is a non-pregnant? Weight of the uterus is 2 ounces. Fundal height is decreasing. Remember, what do we monitor when it's going down? The fundal height again. And this height and the uterus is going down 1 centimeter per day. By 10 days, you should not be able to palpate abdominally. That means that normally the uterus is shrinking, weight is going down, going back into the normal condition. Now the word is, if they give you the word purpural infection, I want you to add the word is purpural, P-U-E-R, purpural is infection. Purpural infection postpartum, after baby has and mother has infection, is called purpural infection. What do you monitor is abdominal pain. What is the sign of purpural infection? Abdominal pain, abdominal tenderness, abdomen is hard, and lochia is foul smelling. Foul smelling is never a good word. Tenderness is not good. Abdominal pain. What is the sign of purpural infection are? After the delivery, mother has infection, is called purpural infection. What are the signs of purpural infection? Abdomen is hard and foul smelling lochia. Lochia is coming out but very bad smell, and the abdomen is tender. Now what do you monitor the mother when we have for the bleeding? Number of pads, weight of the pads, your answer, and no more than 8 pads in a day. If more than 8 pads would be more severe bleeding. 8 pads is okay, no more than 8 pads. Rubra word. Rubra means red. And 1 to 3 days. So rubra, red, for how long the first bleeding is called rubra, for 3 days. 1 to 3 days. Serosa means brownish, pink discharge from 4 to 10 days. Alba is whitish and run 10 to 14 days or longer. Some question, 2 weeks, baby is born and mother has whitish discharge. What kind of discharge is that? You still pick up the word alba. Are we clear? So rubra, serosa, alba. Alba is 10 to 14, but even they give you more than 2 weeks or 3 weeks, mother is having white discharge, you still say it's a alba. Are we clear? So alba. Perineal pads, you assess the lochia. First 4 hours, they give you question. Mother had a baby and the fever is 104 or 102. It's okay. Why this fever is because of answer dehydration. Early few hours, 4 hours after baby is born, mother has fever, maybe 104. Is not abnormal, not sign of infection, could be sign of what? You lose a lot of blood, dehydration. So can be your sign of dehydration. 102, 104, if you have 104 or 102, remember, you're looking for first few hours, within 4 hours time, sign of dehydration, sign of hypotension. Can mother go for shower herself? She can go. But you stay with her. Why? Because of hypotensive. And they can lose blood pressure, they can fall. Safety is number 1. Now, next is menstruation. Return within 8 weeks with among non-breastfeeding mother and check the bleeding for that. Breast engorgement question, 48 to 72 hours, non-breastfeeding mother, and will feel or relieve engorgement. Non-breastfeeding mother avoid nipple stimulation, breast binder, tight fitting bra, ice pack is good, and women may ovulate without menstruating. So breastfeeding should not be considered for birth control. That means they can be pregnant. Now breastfeeding mother, always in engorgement question, support bra is good, ice pack is good, only when mother is not feeding. If mother is feeding, warm soak is good answer. UTI, monitor for UTI infection, within 12 hours after delivery. GI, what are the common complications are after baby is born? Constipation and hemorrhoids. Next page, I will move on. On next page is bradycardia monitor, and ROGAM should be given 72 hours. Mother has been, baby is born. Negative mother and neonate means the baby is positive, and you give ROGAM within 72 hours. In postpartum blues question, what is postpartum blue? Depression. Mother goes in depression after the babies are born. And taking in phase. Taking in phase is 3 days. Mother wants to tired, she wants to rest, that's normal. She can take rest. She's not much interested in teaching. So remember, in teaching question is not good in first 3 days. Are we clear? Why? Because mother is very tired. She's resting. At the time, discharging is good. Taking hold phase is 3 to 10 days. Now, after 3 days, mother is ready to look at the baby and doing all the child care. But if any signs are there, she's neglecting, she don't want to look at the baby, she don't want to learn, that means it's not a good sign. Letting go phase. After 10 days, mother should be very normal. But if she's not making any progress, that may be a sign of depression. It's a lot of hormonal changes. And remember, it's a big responsibility to have a baby and to learn to adjust in new life. So it's a lot of depression, a lot of responsibility, and a lot of people cannot handle it, and they go under depression. Any sign of depression need to be notified, need to be corrected right away, because some depression can be really bad depression. Nutrition question, we said earlier, corrected 300 calories when pregnant and 500 calories when mother is feeding, breastfeeding, or lactation work. You will go on 500 calories. Cracked nipple question is nipple to let it dry, air. Cracked nipple or exposure to nipple, air dry. That's good. That means keep it open after feeding. Keep covering, lead to more infection. Rotating the baby on both breastfeeding is good. Very important next answer. Let the baby latch on areola, not on the nipple. So whole black area, the baby should hold it, not only the nipple. Because if they grab the nipple, that can lead to cracked nipple. Oral contraceptive that contains estrogen should not be recommended. For birth control pill right away when you're feeding. Caffeine you avoid, hormones you avoid. It can affect the decreasing the milk. Everyone should know. Simple answer. But remember the good answer. And these are your good answers are here. Rotating, air, and latch. 3 wording. And I'll tell you, this kind of question would be in exam. Because simple, but we are teaching as nurses. Hematoma question. Hematoma means collection of blood into the tissue, and maybe with forceps or maybe blood vessels have been injured. And it can be a bad, hematoma word is not good, there is a blood. And what would you monitor? Mother has hematoma and your symptoms would be, number 1, abdominal pain. Pressure on perineal area. Bulging mass. Very, very important answer in the second line, inability to void. Mother is not able to pee. What are you assessing? Hematoma, first thing. And so remember how your questions are. Hematoma is very important, and mother is not able to. Mother's hemoglobin, result come back, and they're showing your lab is low in hemoglobin and hematocrit. What does it mean? She's bleeding somewhere, and could be sign of hematoma. Then you will go intervention. Ice is good. Catheterize the mother because she cannot pee. And what do you monitor? Infection. And also, if it is a big hematoma, you got to prepare the mother for what do they have to do? Evacuate. They may have to incise it and drain the blood. Some of the bigger hematoma, they have to do the surgery. So there may be a question. There are questions in Saunders' book. Mother has a bigger hematoma, mother is not able to pee. What do? You prepare the mother for surgery. Are we clear? So these are very good answers, to the point, are there, but you got to remember, before your exam, just review your questions and review some material. So very important, we are nurses, on your calorie question, hematoma questions are, and cracked nipple questions are simple, but those are questions. So what is very important with hematoma? Number one is unable to pass urine. And second, remember, they're bleeding, check for hemoglobin. And also evacuation can be done. Now hematoma are there. Hemorrhage. Hemorrhage means bleeding. First 24 hours, mother is bleeding. What is a normal? You will consider the bleeding or the hemorrhage. I would say, write down the word 500 ml or more than 500 ml in first 24 hours will consider bleeding. Are we clear? So what is a bleeding? 500 ml or more than 500 in 24 hours is considered mother is bleeding. So what do you monitor after the mother has a baby? Her bleeding. She is bleeding more than 500 ml, and that means it's severe in your question. And they might say, mother had bleeding about 800 ml. What is it? It's a hemorrhage. She's hemorrhaging. So number one, I want everyone 500 or more, consider hemorrhage. What would you be monitoring? Which mother is going to be risk for bleeding? In the next line is uterine atony. Uterus is not contracting, so the word is uterine atony. Maybe mother is having laceration. Maybe inversion of the uterus. Uterus has turned around. And late, after 24 hours, early 24 hours, these are the reason for postpartum hemorrhage. I want you to write down also twin delivery. If they have two babies, they risk for more bleeding. And twin delivery may be more late part of the postpartum hemorrhage. But early 24 hours, everyone remember, your question would say, mother is early 24 hours, she is bleeding. What is postpartum hemorrhage? More than 500 ml? Number one. Number two, remember, uterus is not contracting. The word is called atony. Second word is laceration. You got to look, maybe mother has some laceration. Maybe inversion of the uterus. Something is wrong with the uterus. After 24 hours, mother is still bleeding. What do you assess now? Maybe retained placenta. Placenta is not coming out. Maybe there are some clots there. Maybe some part of the placenta is still there. So that's the way you look your question. Now, what do you do? Intervention. Monitor blood loss, count the pads, oxytocin. Why? Mother is not contracting. Are we going to start the Pitocin or oxytocin? Yes. What do you monitor? Mother is bleeding. Hemoglobin. What do you do for mother? Massage the fundus, empty the bladder. Massage is good, empty the bladder is good, start Pitocin and monitor for hemoglobin. Now the next is mastitis. After I finish, we'll take a break. Mastitis, primary seen in breastfeeding mother, mastitis. 2 to 3 weeks. And that's also a very important question because it's infection. So they can ask you, because the whole thing they're looking, nurse, how you handle your patient, how do we teach them? So I want you to write down, mastitis is caused by Staphylococcus infection. In some of your questions is called Staphylococcus. Staphylococcus aureus, A-U-R-E-U-S. A Staphylococcus is common infection for mastitis. Staphylococcus aureus, and how? From the baby's nostril. baby's nostril means from the baby's nose. So these germs are, Staphylococcus can lead to mastitis. And mastitis cause is from baby's infant nostril or the mother nipple, maybe a cracked nipple can get the infection easily. Cracked nipple. So it's very important. Some question I came across, NCLEX question, and that was one of the answer. What was the reason for having mastitis? The Staphylococcus infection. How? From the baby's nose or mother's nipple were cracked. Now data collection. There was another question, and what is the early sign of mastitis? Highlight the word flu-like symptom. They start with flu-like symptom. They feel warm, pain, swelling. But very important answer, flu-like symptom. Intervention. What do? Teach the mother. Hand washing. Hand washing. And breast hygiene. Clean the breast. Heat or cold. You can apply. Manual expression. That means removing the milk. Breast pump every 4 hours. Antibiotic. Mother has to give. When they give antibiotic, can mother feed the baby? Yes. She can continue feeding. And also I want you to add, there was a question. Mother has acute mastitis. Answer was bed rest. So write down the word rest during acute stage. And support bra. And also with the rest, the answer was, 2 answers was there. Increase fluid because there is infection. So rest and support bra is good. Increasing fluid. And you are giving antibiotic and hand washing questions. Okay. So very important. Staphylococcus infection for mastitis. Mastitis is infection. The question, what is early sign of mastitis are, is flu-like symptom. What do? Mother has acute mastitis, bed rest, fluid, support bra, antibiotic, hand washing. Remember, all our questions in NCLEX are select all that apply. So we got to know more than one answer. So I find anything, I keep adding in my notes. And so any questions I do and I find something, I say, oh, I think I should add that. So I share with you guys. So let's take a break and then we'll continue whatever left.